Hello, and welcome to the Princeton Spine and Joint Center podcast. My name is Scott Curtis. I'm the Director of Sports Medicine here for the practice. I just had a great conversation with Scott Giallella, who is a vestibular physical therapist over at Hamilton Physical Therapy Services. We talked a lot about vestibular physical therapy, what it's used for, and what kind of patients would benefit from it. We talked about the role of physical therapy in concussive symptoms. And finally, we also talked about different types of physical therapy for fall reduction in individuals who may have frequent mechanical falls. So if any of this applies to you, I think this is a great episode. If not, well, we'll catch you next time. Please enjoy. Hello, and welcome to another episode of the Princeton Spine and Joint Center podcast. My name is Scott Curtis. I'm the Director of Sports Medicine here for Princeton Spine and Joint Center, and we have a great episode planned for you today. I'm here today with Scott Giallella from Hamilton Physical Therapy Services. He's a physical therapist who is trained in vestibular rehab, and we're going to be speaking today about vestibular rehab, physical therapy for balance issues, and some concussion type of rehab protocols specifically for balance. So, Scott, welcome to the episode.
Thank you for having me.
And before we kind of get into the nuts and bolts of the topic, tell us a little bit about yourself and kind of your journey into physical therapy and specifically vestibular physical therapy.
Yeah, I was always interested in the body. Through high school, I got interested in just general fitness. Always interested in like what exercises I can do to help me be a better athlete. Not really big framed person, so I always felt like I had to work a little harder, so that kind of got me interested in that side of the game. Then as I got into college and started to have to declare a major, I started thinking about maybe physical therapy was a good option. It became a really popular job at the time. I mean, it was always out there, but I think it really blossomed and became a really popular course of studies for people to take when I was in college.
Where did you go to college?
TCNJ. It was Trenton State when I was first there, and then it became TCNJ. And then I went to Widener University and got my Master's of Science in Physical Therapy. We were actually the last class that didn't get a doctorate. So I may go back and get my doctorate eventually, but again, we were talking about family life is a little hard sometimes to make time.
It's a lot easier said than done sometimes.
And then I started with Hamilton Physical Therapy 17 years ago, right out of graduate school. It was my first job, and I've been happy there, so obviously I've stayed there. I became partner over 10 years ago. Started vestibular rehab, volunteered by the old partners probably 15 years ago. They said, you know, we're getting a lot of phone calls, patients complaining of vertigo. And that's really what it started out as, vertigo. It wasn't so much vestibular rehab when I was volunteered to go do it. And the course was really geared towards that, treatment of benign proximal positional vertigo mostly. And then over time, having seen more and more clients, I began to obviously realize that everybody that comes in is not Bppv, although they may complain of what they're calling vertigo isn't necessarily vertigo. It's more of a dizzy, unbalanced, unsteadiness that they're also, after you delve a little deeper, they're saying, well, it's not really vertigo. I mean, it's not spinning. It's more just an unbalanced, just not a lack of equilibrium that they're complaining of.
And that's really what vestibular rehab is, right? It's so for the people that don't know or don't understand what vestibular physical therapy or vestibular rehab is, it's physical therapy or rehab specific for balance issues and dizziness issues. Is that pretty coherent? Or
I would say that's accurate. Yeah, I mean, and when I start doing my evaluation with patients, a lot of times when I realize it's, because I'll get referrals straight for like balance gait dysfunction. And even if it does appear to be more of a musculoskeletal kind of contributing factors where they just have a loss of strength, loss of flexibility, and their balance, and it's then affecting their balance and their balance strategies, I always will even just do a screen for vestibular causes and contributing factors, and it almost always has a lot of contributing factors that are vestibular in nature. And if a patient says, I'm fine unless I turn, or I'm fine unless I like try to track something that like a car that's moving, and then I start to feel like I'm moving with it, and then I'll say, well, it's most likely there's definitely an inner ear issue, contributing factor. And when I say inner ear, I mean that's part of the vestibular system.
Yeah, let's kind of talk about that. So the vestibular system is quite complex, and any piece of the vestibular symptom that we're going to define may cause a similar type symptom of quote unquote dizziness or off balance. So when you have a patient who's referred to you for dizziness or for vestibular rehab, what's kind of your initial evaluation, and how do you tease out which system is involved and which system you really need to concentrate on?
Okay. Yeah, that's a good question. I'll obviously take a history. When did this all start? I know that we're eventually going to talk about post-concussion, but if somebody says it was like I got struck in the head, then I know I have a little bit better idea of what's really going on, but let's just go back to vestibular. When are you getting the symptoms? How would you describe the symptoms? If it is that vertigo, which I'll describe to the patient, it's a sensation of spinning.
Okay.
It's not necessarily that unbalanced feeling, disconnected feeling, but that is something that I will consider as being part of vestibular.
Right.
And then I'll make sure, you've seen your cardiologist. It's not something that is low blood pressure related.
Okay.
And sometimes I will take their blood pressure and kind of test them in changing positions to see if that's a contributing factor. After I take a thorough history, and if there is any mechanism of injury, I'll get into my objective testing, which is ocular motor exam.
Okay.
So I'll do, have them follow my finger, have them focus on my finger, shifting their eyes, their gaze, gaze holding type testing. And then I'll also assess their musculoskeletal system. If they're, I imagine they're going to have some, if we're talking about somebody that's a little bit older in most cases, they're going to have some musculoskeletal issues, postural changes, limited flexibility, especially in their hamstring. So it's going to put them in that kind of rounded position, and that can change the world around them, and sometimes they don't understand that they're changing. So it's going to change their way that they react to it. And then if I feel that there is some sort of vertigo situation going on, I will do all of like the Dix-Hall-Pike test, which for our viewers, it's, they sit on the table and I sit them down quickly. Head goes off the table. Head is turned towards the side of the ear that I'm testing. And then I'm waiting. It's usually delayed, and I'm looking for what's called nystagmus of their eyes. Obviously, if that's the case, and my hands in my head are clapping, because then I know that this is going to be a fairly quick treatment progression.
So if there is a positive Dix-Hallpike, as you're talking about, what does that indicate? What part of the vestibular system does that indicate?
It indicates that there's crystals that are supposed to be in an inner part of the inner ear that is helping give the body feedback with movement. They're out, and they're in one of the canals of the inner ear. And after I let the nystagmus stop, I'll bring them through a maneuver, and then I'll have them sit. And usually I'll make them sit for about 5 to 10 minutes. Let everything settle, almost like I describe. It's like a snow globe. If you're shaking the snow globe and you put it down, it's going to take a few minutes for those crystals to settle.
I like that.
So even if we did clear out all the crystals, I want to make sure everything settles, retest them. If I get a negative test, that's fantastic. I'll reschedule them, 2 to 3 days out, telling them like a post-maneuver type instructions, which aren't as indicated as it used to be, but I'll usually tell them don't sleep on the side that I treated, sleep with a couple extra pillows, don't whip your head around, testing if it helped. And then when I come back, I'll retest them, and if it's negative, we'll get started with some habituation exercises, which helps get rid of any residual symptoms they may be experiencing, which isn't always the case. Sometimes they'll come back and say, I feel fantastic. In which case you look like a hero. Which I said, it's like one of the only diagnoses in physical therapy that you can get them better in 1 to 2 visits.
And that's a great feeling.
Rarely do you see someone come in with like back or neck pain and they're like, well, I'm great. It's usually going to take a little bit longer.
So, just to kind of step back at the vestibular system. So before I got into sports medicine, I was, primary care, internal medicine, and we would get patients with dizziness all the time. And it's always difficult because the term dizziness is so subjective for each individual. individual. And when you look at the whole, quote, vestibular system, there's a lot of different things that could cause dizziness. So you talked about the inner ear, certainly the brain and neurogenic issues, cardiogenic issues, and things like low blood pressure or a slow heart rate. If you get up too fast and you can't compensate, can cause some issues. The musculoskeletal system, if you have a particularly inflexible hamstring or an area of pain and you're going to start to get off balance, that might be perceived as dizziness. And of course, medications can cause dizziness themselves.
That's a good point.
Whether it's a medication designed to drop your blood pressure and it's doing too good of a job, so to speak, or it's a medication like a muscle relaxer that has the side effect of dizziness. Any one of those could cause issues. And then finally, we learned, over, especially with some of the work done with concussions, how much the ocular movements play a role in dizziness and be able to track things. So it's quite complex, and sometimes there's even more than one issue going on at once.
Absolutely.
And of course, it's the physician's job, but sometimes us as physicians kind of get an idea, so to speak, and maybe adjust the medication, but it's really you and your staff on the front lines who are kind of going through it in a little bit more detail and asking the more appropriate questions and doing different maneuvers. And we rely on you as the therapist working with the patient to really figure it out and try to do some of the work.
Yeah.
But as a therapist, sometimes your approach is different for different problems. So how is your approach for, let's say, somebody coming in with a rotator cuff injury different than the person coming in for vestibular problems and dizziness and balance issues?
A lot of times with someone that comes in with any musculoskeletal problem, you're, gaining your objective measures and you're looking where they have deficits, and then based off their pain reports, you're kind of progressing off that. With vestibular, it's so different with everyone. Somebody, you can almost do very minimal activity, and it can just set them off, especially with a post-concussion type situation. And a lot of times with those clients, well, every time with those clients, I'm asking them where their baseline is when they start their treatment that day. Where are you right now? Are you having symptoms? And I'll say, like a pain rating, I'll say, well, where's your symptom rating? And they'll say, well, I'm not so bad right now. Maybe I'm a 3. And after each series of exercises, I'm asking you, where are you right now? If they're creeping up 2 to 3 on their scale of what they consider 2 to 3 for that scale of 0 to 10, I'll usually have them stop, give them 3 to 5 minutes, and then resume after that. Because I kind of feel like if you keep pushing it, you get to that point where it's like a point of no return for the day. And then it can be like a just a wash for their treatment session. You're not really getting anything out of it.
Is that different than if you have somebody with shoulder pain and you ask them what their pain scale, and let's say it's a 3 or 4, and then you start doing an exercise and it starts to creep up during that exercise? Do you shut them down, or do you kind of modify the exercise?
Modify the exercise, and a lot of times it's that when you take that stretch off the situation or whatever's creating the pain will diminish very quickly. And take a break. I'll be back in a minute. We'll resume our stretching. We'll resume our activities. If they're like, that exercise really set me off. It's really killing me right now. Well, then you document that maybe that they're not really ready for that. And maybe we're going to wait a few visits. But usually when they leave that day, they're kind of back to baseline. We have good information of where to go on the next visit, but they're not done for the visit or done for the day, and then probably most likely not going to go home and have to take pain medication and anti-inflammatories just for the one activity we do with them. However, patients with vestibular, they may tell me the next session, I know we didn't feel like we did a lot, and they'll even recognize that. It's like, I didn't think I did much, but I was done for the day. I was exhausted. I got a headache, and then you try to avoid that situation as much as you can, but because everybody responds differently, and sometimes it can be, I don't want to say out of left field, but it almost is, like they're progressing so well during that session, and then suddenly they're like, whoa. You kind of
went over that threshold that really set them back.
Yes.
Yeah, to me, I kind of the background or the backbone of vestibular physical therapy is not so different from what you're doing with musculoskeletal physical therapy, in the sense that you kind of have the subjective findings of a pain scale or how you're feeling, and then you try to do an exercise or a therapeutic maneuver to diminish or get your baseline a little bit lower, and then you reassess using that subjective scale. But I understand your point that sometimes when there's kind of a backward slide in terms of pain with musculoskeletal, you could easily get back to that baseline.
Right.
But with vestibular, you may not be able to get back to it. So how do you, if a patient is discouraged because they were set back with a vestibular rehab exercise, how do you kind of give them the confidence that, okay, we're going to try something different, or we're going to take a different approach?
I just explained to them that, I mean, we're dealing with different systems than, even though, as you said, it's similar, it's more systems that respond slowly. Over time, you're going to see improvement, but it may not be trackable improvement day to day. It's going to be a slow progression, and you may look back last visit and say, I don't think I've really made much improvement. But if you look back a week or two, you're going to see improvement. And it's just going to have to be a slow process, and you're just going to have to accept the process and kind of buy into the fact that it is going to be slow.
What's the time course that we're talking about with any kind of meaningful results with, some patients, just from a musculoskeletal perspective, get frustrated that physical therapy is not a magic pill or an injection or a surgery where, you're going to see significant results in, a week or a few days. What's your expected time course with vestibular rehab in terms of getting, let's say, 50% better versus completely normal? Are we talking about days, weeks, months? What do you think?
With the Bppv that we were discussing, usually I'll say, 3 to 6 visits, and even 6 visits may be pushing it a bit. Sometimes it's more like the 2 to 3 visit range. Post-concussion type situations, people that come in and say, this has been going on for years and I get it on and off, and it turns out it's not a Bppv situation. Maybe it's some sort of vestibulopathy weakness or something that's occurred over time and just gotten worse. That's going to be something that's a little hard to grasp for them and for me to tell them exact time frame of when things are going to improve. But I usually will say, we're going to give what the doctor recommended, which is that 12 sessions typically is 3 times a week for 4 weeks. They may not be able to tolerate 3 times a week. But whatever the time, but even if it's twice a week, let's say in a month, and then we reassess at that point. I'm hoping over the course of that 4-week period that they're seeing anywhere from 10 to 25% improvement. Sometimes we're a little more towards the maybe 25 to 50. But if we're dealing with something that's been going on for a long period of time, it's going to be a little bit slower progression.
And a lot of that is patient education and counseling, right? I'll tell patients kind of the similar type thing. The longer this has been going on, the longer it may take therapy to kind of correct it or see meaningful results. So, if you've been having knee issues for a full year and this is the first time you're seeing me, those knee issues may not get better right away. It may take more sessions than if you came for me, just for mild pain over a course of a month. So I think it's important to at least set the expectations or kind of give a realistic time frame of when we're going to get better. Because you and I both know that some patients get easily frustrated after 1 or 2 sessions. They don't see that meaningful result. So they stop going or they come back to me and say it's not working. And I think it's just really important that we're all on the same page from a physician, a therapist, and a patient perspective of what's the realistic expectations.
And if sometimes I'll compare it to, like, if the doctor prescribed you an anti-inflammatory, you don't take 2 and say, it should be all better now.
Yeah, of course.
So you're just going to have to give it that length of prescription that the doctor and we agreed to, and then we reassess. If after 6 to 8 sessions you're seeing absolutely no improvement, maybe it's indicated that I refer them back to the physician. Or if they're seeing significant improvement, maybe they're not going to need all the visits that we recommended. But
and hopefully that's the case, that they're moving in the right direction quickly, because that means that I did my job appropriately and referred them to you, and you're doing a great job of getting them better. That's a win-win-win for everybody. And I wish everybody was like that, but you and I both know it's not always the case.
It's a little hard to get them on the same page as far as, like I was saying, buy into the fact that it's going to be a little bit of a longer process at times.
So you talked a little bit about the Bppv type of maneuvers, the Epley maneuvers that you were describing. What are some other types of maneuvers, or what are some of the exercises that you do with a patient when you've made an accurate diagnosis and you want them to start getting better?
Well, and just to take one little step back, I just want to also mention, so you were talking about like the subjective aspects that the patients are complaining of. I also want to also gain as much objective that I can. So to assess their balance, I'll typically do the Romberg. So I'll have them in a tandem stance, so heel to toe, hands across their chest. I have them on 4 different conditions. So on the ground, eyes open, ground, eyes closed, foam, eyes open, foam, eyes closed. We also at our facility in Hamilton have a Biodex balance system where we can do the modified clinical test for the sensory integration balance. We
use that in fellowship when testing for concussions.
And it also produces a report for us. It compares to medians where they should be. It doesn't give you an actual number, but it has on the graph where they think they should be and if they fall left or right. So that's something that we'll use.
I don't know if you've ever done it personally, but in fellowship, our program director had us try it out, and it is hard. It is hard to maintain the balance, especially even with the flat surface and your eyes closed. Once you take away that ocular motor reflex, it's much harder. Put the foam on there and close your eyes, you're wobbling all over the place, and that's normal. That's kind of a normal.
And I explain that to them. You're going to have a lot more difficulty because you're taking out your visual system, you're taking out your somatosensory, so to a certain extent. It's not giving you consistent feedback that the ground is giving you. And then I can establish some more goals. So back to showing them that there is improvement, and so they're not getting as frustrated. Every, let's say 6 visits, maybe I'll get them back and test them again, even if I'm just doing the Romberg, not necessarily on the Biodex with the report. And I'll say, the first visit, you were only able to hold for 8 seconds, eyes closed on the foam. And now today it was 15 seconds. So even though your symptoms seem consistent to you, there's improvement that's occurring. So that's
sometimes that does give them
a little bit of encouragement.
Extra, a little bit of extra confidence. When we use the Biodex system in fellowship, it was I always said that it's just a snapshot in time, right? So you really need to kind of get that baseline first and then look at the objective measurements. We always did it with, concussive symptoms that they would get on as soon as they were having concussion symptoms. And then as we would go through the treatment, we would retest them and similar to what you're doing with your patients, just showing them, okay, you're starting to get a little bit better. And so that's really important. So other than kind of, so you're talking about the objective testing. What are some of the exercises that you're going to start working with?
So I always start them out with gaze stabilization exercises. Sometimes I'll do Brandt-Daroff exercises, which are habituation exercises, where they sit on either maybe the side of their couch or the side of the plinth at physical therapy. And they're lying down quickly to one side with their head turned to the opposite direction. That's more for vertigo, but even if patients are complaining of symptoms when they lie down in bed or get up with a post-concussive type situation, sometimes I'll have them do that. Again, you also have to think, is it orthostatic hypotension? Is it blood pressure related? But in many cases during the evaluation, I've already kind of ruled that out. So then I think this is an appropriate exercise to do. So gaze stabilization is like the vestibular ocular reflex, where I'm either having them use their finger, or a lot of times you'll see in our clinic sticky notes with X's. And they're keeping their eyes focused on the X while turning their head side to side. And then I have them do up and down. I'm starting out in an easier type condition, seated, seated eyes opened. And then sometimes they'll even progress to seated eyes closed, just to show them, to give them a little bit more awareness of what their eyes are actually doing, kind of take out. And then I'll have them open their eyes at the end of the 30-second interval and see if their eyes are still focused on the X. Then I'll kind of progress to different situations, not unlike what the Romberg test. So I'll have them do it in a standing position, and then sometimes if they're ready for it, I'll progress to a standing on a foam, eyes opened. Then we'll take a step back and go back on the ground, but eyes closed, and then ideally being on the foam, eyes closed while doing head movements. And then to make it more functional, we progress to them walking with head movements.
That's similar to, again, any kind of musculoskeletal rehab process, is that you start out with basic things and then you do a functional progression back to realistic and real world type experiences. I think patients or at least when I've talked to a number of patients who complain of dizziness, and usually it's because of Bppv driving. Driving's a big issue because you're constantly turning your head. And we'll often look at the cervical spine and see, is there any kind of underlying arthritis, or how could we fix that? How do you simulate a driving situation where they're constantly turning their head in the physical therapy controlled setting?
We actually do have a simulating machine that they could sit if we wanted to make it as specific as possible.
Nice.
They could sit, and then we would tell them to turn, to simulate them turning.
Nice.
Or even just sitting and simulating it, and just maybe having rather than the vestibular ocular reflex, we'll do the cancellation of the reflex. So that means that their eyes are now moving with their head. So I'll have objects to their left and right.
Okay, cool.
And I'll have them turn and focus on the X, and then come back to midline and turn and focus on the X.
Okay.
So they're really keeping it in focus and not just whipping their head and then coming back to midline.
Sure.
And you made a good point about the cervical spine, because sometimes patients, not even necessarily post-concussion, but people know that they're going to get dizzy if they move their head.
Yeah.
So they kind of get into that guarded,
correct,
where they're not moving their head.
They're moving more of their shoulders type situation.
So I'll try to break that pattern, and sometimes even just do some manual stretching with their neck, and address some issues that might be coming from their cervical spine. And that will sometimes help them break that cycle of like you were describing, moving with their shoulders rather than their neck.
So we've mentioned concussions a bunch of times right now. How does your approach with so a concussion, and we could talk about this all day, is basically a head injury that cannot be diagnosed on any kind of blood work or CT scan or X-ray at this point in time, that has prolonged neurologic symptoms, and that sometimes includes headaches. A lot of times it includes dizziness or nausea or poor balance. How does your approach with a concussion patient? Let's say the senior football player who got his bell rung and is held out and needs some help with getting better from the concussion standpoint. How does your approach differ with that compared to the layperson who is just getting this sudden onset of dizziness?
I mean, the evaluation isn't much different.
Okay.
I mean, their history is going to be different, obviously. I do an ocular motor exam.
Good.
I will do balance testing.
Okay.
I'll assess their cervical spine motion, maybe even a little bit more, because that there may be some sort of maybe whiplash injury of some sort that's underlying as well. Not in every case, but I will sometimes test them for Bppv.
Okay.
I have had a few instances where not necessarily the younger athletic population, but someone that hit their head, and they're describing symptoms that are consistent with post-concussion, but some of the things just don't add up to me. So I said, well, let's just test you for the Bppv. It takes a whole 30 seconds to test you. Sure. And in some instances, they did also have Bppv, so then I was able to reduce some of their symptoms with that right off the bat. Right. But then they're still having the post-concussion type symptoms. But a lot of the exercises are similar, a lot of gaze stabilization. Okay. We want to get into eventually some like submaximal type exercise, because physiologically they're not responding well to exercise or even movement in general. Yeah. It'll kind of trigger that internal fight or flight response, and then they say, if I go up the stairs, if I do anything that makes me feel like I'm exerting myself, I feel the onset of headache. Yeah. I almost feel like my hands are getting sweaty. And so you get them on a treadmill. So that's a lot of Dr. Letty's work at a University of Buffalo. Sometimes treadmill, sometimes bike, but I'll use the treadmill sometimes even just to assess the progression. Yeah. The whole treadmill protocol. Yeah. And see where they're at. I'm a big fan of that. And there's more and more research coming out that shows that we should be doing that a little bit sooner rather than later. There was, this whole kind of theory of cognitive rest, which is still true. We definitely don't want you getting back on the field and, obviously getting second impact syndrome or risking another type of hit. But we also don't want you to go in a concussive therapy where you're just laying in a dark room for 2 weeks and can't do anything, because studies are showing that your symptoms will be more prolonged and, you're isolated, especially with, kids. They're away from their friends. They're
their homework is backed up, so that makes things worse. And now there's kind of a 180 in saying, okay, let's get them doing as much as they can, within a tolerated confinement, with schoolwork, with frequent breaks, or with exercise, saying at a sub symptom type of threshold. So I'm a big fan of that, and I think it does help kind of speed up some of the recovery. Some of the other work that's focused on concussions has to deal with the vestibular ocular system. And Dr. Collins out of UPMC has done a lot of work about the different types of concussions. So, what I always tell patients is not every concussion is the same. There are some concussions that are headache predominant. There are some concussions that are more emotional or psychological predominant. But the big theory over the past 5 or 6 years has been how much of the predominance is coming from the vestibular ocular system. So part of my evaluation of concussions is doing the BOMS testing where, we're having the eyes gaze and see do your symptoms get worse and, rotating your head. And there is a considerable amount of patients with concussions who need the vestibular therapy, not just the exercise therapy, but won't get better without the vestibular therapy. So it's something that I will very quickly test for and refer to somebody like you for the vestibular training. With the non-concussion patients, do you ever do kind of a similar type approach with exercise therapy for speeding up some of their balance issues?
Yeah, we'll do some general conditioning exercises if I feel like there's musculoskeletal contribution, or you got to kind of take case by case.
Sure.
If there's someone that is saying, I haven't been doing this in a long time, I would really like to get back to doing it, and then we kind of take that and tailor their program according to that. But I think definitely I do have them do just general conditioning exercises and strengthening, which is good just to get them going. I mean, we all know what the effects are of exercise on the body, not just physically, but mentally.
Yeah,
it kind of gives them that feeling that I can.
Yeah.
And kind of maybe motivates them a bit.
Yeah.
So I'll do some hands-on stretching, some hands-on activities, maybe on the table. Definitely do some exercise. Then we kind of progress from there more into maybe the vestibular-based exercise, or vice versa.
Sure.
Whatever the way the treatment will kind of go that visit. But I definitely kind of try to hit all the systems a little bit. So even if it's more of a musculoskeletal, I'm definitely addressing vestibular issues, even if that's not what's creating most of the situation. Right. And also vice versa. If it's more vestibular, I'll also address the musculoskeletal.
Yeah, and I'll often tell patients that there can be more than one problem going on. So, for example, when I'm seeing a patient for shoulder pain, I always test the neck. Because if I don't test the neck, if I'm not looking for a neck issue, I may never get you better because maybe it's, 60% of your pain is coming from the shoulder and 40% coming from the neck. If I just look at the shoulder, I'm only going to be taking care of 60% of the problem. Right. You're going to keep coming back to me every time saying that you still have a little bit of pain. I think it's probably the same approach with you. If you don't address all the systems, the musculoskeletal, the vestibular, then you may be missing something and may not get them fully better. So I like kind of taking the whole systematic approach.
And ultimately, we want everything to be functional.
Sure.
So as we kind of progress and get out of those, the beginning stages of maybe doing most of the exercises on the table, most of the exercises seated, we want to get into more functional-based movements. Yeah. So the walking is like the beginning of it. But then even if they say, well, I get it when I go grocery shopping.
Right.
So maybe we even simulate it as much as we can.
Okay.
Or I get it when I'm putting away my dishes in the morning because I look up and I'm putting it, so maybe I'll have them simulate that.
Good.
And as far as post-concussion, if they're the athlete, obviously we want to eventually get into some sport-specific movements.
Right.
As soon as they're cleared to do those type of activities.
Kind of progress through the return to play protocol. So one of the functional things, and I'm glad you brought this up because that was going to be my next point, one of the functional things that I always get concerned about are falls. More frequently in the elderly population, more so because studies show that, especially with women over the age of 70 or 75, if they have a fall and sustain a hip or pelvic fracture, there's actually an increased risk of mortality with that. So it's not something that I take lightly. When I send a patient for balance issues or falls to your office, is there any kind of specific therapy that you look for, whether it's vestibular or not, to help kind of fall reduction risk?
Well, the evaluation might be a little bit different. I'm still going to probably be assessing some vestibular, contributions to their presentation. But I'll usually will do either the Tonetti or dynamic gait index or timed up and go.
Okay.
Maybe functional reach or something that's a little bit more appropriate for what their diagnosis is as part of the evaluation. And then the treatment protocol, the treatment that I'll usually do isn't much different as far as addressing their musculoskeletal and the vestibular side of it, but the actual balance training part of it is going to be more functional based, having them working on maybe stepping over objects, sidestepping, maybe crossing over, education.
Sure.
I find that a lot of times people will lose their balance, either going into a new room because the threshold are changing from surfaces, maybe even planning out what they're about to do a little bit more than maybe they have, thinking about what they need to do to get through this obstacle rather than just do it and used to be automatic when they were a little younger. When they go to sit down, make sure the chair is right behind you. Getting rid of all what I call death traps in their home. We used to do a lot of home therapy, and I'll call them death traps because they'd have a million throw rugs and wires. Like, why do you need all these throw rugs?
Right. Some people really like throw rugs.
Yeah, on top of a rug. A throw rug on top of a rug. So I'll say, you don't need these.
Right.
And then I'll even go in sometimes and like rearrange all their wires like you were saying. I'll say, let's just see if we can put them over here. Get a power strip. Get it out of the way where you have to step over it all the time.
Right.
Especially if they use an assistive device, because then that's going to just get wrapped up on it. So I think education is a bigger part of it than the straightforward vestibular and post-concussion situation. If they have had falls, we need to kind of assess a little bit closer why. Or maybe working on their balance strategies. Even in some degrees, I've worked with patients on how to get up from the ground. We don't want them to be down there.
No, but it's important to teach them so they don't have another fall as they're getting up from the original one.
Just teach them how to do a half kneel and then get up from that situation. But obviously, maybe get them on the biodex a little bit more because there's a lot of treatments you can also do on the biodex. Working on some weight shifts, working on like what their limits of stability and postural stability. And a little bit more balance driven rather than vestibular driven.
And the fall aspect of things is similar to when a patient comes in and says, I'm dizzy all the time. A similar type chief complaint would be, I'm falling all the time. And you have to tease out, is it because of a musculoskeletal problem? Is it because of a vestibular issue? Is it because of a home issue, medication? So I'm kind of lumping in the fall aspect of things because to me the therapy is kind of a similar type of approach as it is when a patient is coming in for dizziness and having vestibular issues.
Very similar, yeah.
And of course we don't want anybody to fall because like I said, especially if you're on blood thinners or you have other medical issues, it could be a really bad thing. So a lot of times patients, especially if they said that they've done therapy, I did therapy for an ankle or a shoulder and it didn't help me so much, I'll say, but this is a different type of therapy, and this is the type of therapy that is more functional than anything else. And so I really like your approach with it.
And I think it's also hard sometimes, and at times you have to get the family involved if you're really identifying that maybe they need an assistive device. And then they're always gonna, most cases, resist it. I have one, but I don't think I need it. It's in the closet, and it's tough. It's a tough topic to kind of
it is, especially when you have the patient who's in their 80s or 90s, but they still have the mind of a teenager and a 20-year-old. Exactly.
Their whole life,
And, it's just, like you said, a big part of our roles, both as physicians and physical therapists, is education, right? And that is something that, unfortunately, with the way that medicine works, we don't have as much time to educate as much as we'd like to, but we do what we can, and it's important not just for us to educate, but for the patients and the family to listen and take that advice. Sometimes that's a lot easier said than done.
Yes, I agree.
So I think that we've really hit a lot of good topics about vestibular rehab, post-concussion rehab, fall reduction. Is there anything else that you want our listeners or our viewers to know or kind of think about whenever we're talking about balanced physical therapy or fall reduction? Anything we missed?
I mean, not that I can think of. Just kind of what we were talking about. That in almost all cases, it's going to be a process. It's going to be sometimes slow, but we'll walk them through it. And because I'm one of the partners, I'm always available if they're interested in stopping in and discussing anything. taking a look at our facilities, getting an idea. I can walk them through some basics and some ideas of what our treatment would kind of entail.
Yeah. And you guys are all over the place too.
Yeah, we have an office in Robbinsville where I met you. We have an office in Princeton. It's only open to the Princeton University students and dependents and staff.
But your main one's in Hamilton.
And our main one is in Hamilton, yeah. And that facility is probably the best for these type of diagnoses, just because it's an open area. There's a lot of resources. We have a lot of things that can be done at that location. But I'm always available to answer any specific questions that patients may have.
Well, fantastic. Yeah. And I'm glad that our viewers and our listeners got a chance to hear you and I speak about this. I really appreciate your time, and thank you so much for joining us.
Yes, thank you for having me.
Yeah, great.